Usually, you get numerator and denominator data for quality reporting from different sources. How do you get denominator data?
The common theme here that I introduced in the last question is that there is great variation in the market, and flexibility is the key to serving all comers. Some of our clients are able to generate flat files. That's a simple data extract from the practice management system that includes all of the data we need. This may be a draw from multiple tables to bring them all under one. We prefer big raw files with a minimum of filtering. Every time a data set is filtered or otherwise handled or subjected to manipulation, we see errors and data loss. It's best to limit only by beginning and end date, and we can do the heavy lifting of filtering on exactly the data we want when we have that set in hand. Many practice management systems contain some canned reports into which some simple parameters can be introduced, such as that desirable beginning and end date. If one of those canned reports contains all the data we need, those can be quick, easy, and useful. It doesn't matter if there are fields included in the report that we don't need. It's easy to filter on our end and to take what we need and discard the rest. By far, the most common source of practice management data is 837 files. These are files that your practice management system prepares and sends periodically to your claims clearinghouse to go on to insurers for payment. These usually persist as an archive file in your system and can be periodically sent to us as the foundation of your denominator calculations.
So when we're talking about denominator data and eligible instances, we often see data completeness come up. Where does data completeness fit into all of this?
For the performance years 2023 and 2024, Medicare requires for the merit-based incentive payment system and the clinical quality measures option of the APM performance pathway that you submit performance data on at least 70% of your eligible instances. Starting with the 2025 performance year, Medicare has queued that data completeness criteria to go up to 75%. Also, remember that measures have a minimum denominator count as well. It's called a case minimum. With a few exceptions, that case minimum for most quality measures is 20 eligible instances. If you have fewer than 20 eligible instances for the measure, you won't get credit for submitting it. The preliminary count of eligible instances we make from the claims analysis is a great first pass determination for both the requirements for data completeness and eligibility based on case minimum. If our preliminary count is below case minimum, clinical data that is used to complete that eligibility analysis will never increase the count. It can only decrease it. If you fail case minimum on the preliminary count based on claims, you cannot get credit for that measure. Now, data completeness is interesting. If the clinical data is coming from your electronic health record, your EHR, and there's only one instance of a single EHR in your practice, by Medicare's definition, your data is 100% complete. It becomes an issue if your data comes from multiple EHRs, or if your data comes from a derived source, such as a tumor registry. In the first case, all clinical data comes from a single EHR. Medicare allows us to assume that the data is complete. For most measures, when we find performance data, performance is met. When the data is not found, performance is not met. All eligible instances are covered by one or the other possibility. And some of you recognize that I'm bleeping over a couple of complications, which just make this a more complicated discussion, those being inverse measures. The other issue being exceptions, which can create that third category of performance met, accepted or excluded, and performance not met. When the data is from a derived source like a tumor registry, finding performance data indicates performance is met. But lacking performance data, the question arises, is performance not met, or was there a failure to create an entry in the separate registry? Medicare requires us to consider the lack of data to be a lack of reporting, a decrement to the reporting rate. The exception to that rule is when the secondary data set explicitly documents a lack of performance. So if we can show the logical argument that the lack of data is reliably shows lack of performance, or that you actually explicitly describe a patient lacking performance in that registry, then we can improve that reporting rate from that derived data source. In complex systems where different EHR instances and possibly even paper records exist, it can be impossible or perhaps just cost prohibitive to get data from every system. Medicare's data completeness criteria determines how hard do we need to try. Once we access 70% of the cases, we don't need to go any deeper.